Today we're going to cover the differences between the pharmacology of dobutamine and milrinone. Starting with the class of dobutamine, it's a synthetic sympathomimetic, whereas the class for milrinone is that it's a selective phosphodiesterase 3 inhibitor. The main uses for dobutamine is that it's an inotrope for cardiogenic shock. And milrinone can be used for the same reasons for cardiogenic shock, but it's also more beneficial for pulmonary hypertension, right heart failure, after coronary artery bypass surgery, and for beta blocker toxicity. The main mechanism of action for dobutamine is that it's a beta-1 adrenergic stimulant, and it binds to the beta-1 receptor, which stimulates the GS protein-coupled receptor. This causes a rise in adenylyl cyclase, which causes a rise in cyclic AMP, and ultimately causes a rise in calcium. A rise in calcium causes an increased inotropy. It can also bind to beta-2 receptors, which are G-stimulatory protein-coupled receptors, and this, by same pathway, causes a rise in cyclic AMP, increases the level of protein kinase A, and this results in a fall in myosin light chain kinase activity. This results in smooth muscle relaxation and vasodilation. It can also bind to alpha-1 receptors, which is a GQ protein-coupled receptor. This causes a rise in phospholipase C and an increase in DAG and IP3, which ultimately causes a rise in calcium and vasoconstriction. So for the mechanism action of milrinone, phosphodiesterase 3 is inhibited. This causes a fall in the breakdown of cyclic AMP. Consequently, a rise in cyclic AMP, as mentioned before, causes a rise in calcium, and this causes an increased inotropy. Similarly, in smooth muscle, a rise in cyclic AMP leads to decreased myosin light chain kinase activity and smooth muscle relaxation, ultimately leading to vasodilation. In terms of presentation, dobutamine comes as a white powder that needs to be reconstituted with glucose. Interestingly, it's a racemic mixture, so the dextro form is a potent beta-1 agonist and alpha-1 antagonist, whereas the levo form is an alpha-1 agonist. Overall, the net effect is that the alpha antagonism and agonism are neutralized. In terms of the presentation for milrinone, it's a colourless yellow solution. The dose of dobutamine is a roughly 2 to 20 mics per kilogram per minute, and that's given intravenously, whereas the dose for milrinone is 0.375 to 0.75 mics per kilo per minute, and it can be loaded, though it's often just started at the desired rate. The onset for dobutamine is quite rapid, whereas milrinone has a slow onset of 5 to 15 minutes. The duration of dobutamine is very short duration, around 5 minutes, and this makes it much more titratable. Whereas the duration for milrinone is longer, in the realm of 3 to 5 hours, and this is prolonged in renal failure. In terms of the pharmacokinetics, dobutamine is given intravenous only. It has a volume distribution of 0.2 liters per kilogram, an unclear level of protein binding. It is metabolized rapidly by catechol-O-methyltransferase, and its metabolites are renally eliminated and they're inactive metabolites. On the other hand, milrinone pharmacokinetics, it's primarily given intravenously, but it does have an oral bioavailability of 92%. Its volume distribution is slightly larger at 0.4 liters per kilogram and has a plasma protein binding of 70%. It has minimal hepatic metabolism, around 10%. It's primarily eliminated by the kidneys in the unchanged form. This is important because it can accumulate in renal failure. So the half-life of milrinone is around 2.3 hours in heart failure, and this extends to about 8 to 12 hours in renal failure. And there are studies showing that it can extend to 20 hours plus if the patient's on continuous renal replacement therapy. Compare this to the half-life of dobutamine, which is only 2 minutes. In terms of pharmacodynamics, it can be thought of as both an inotrope and vasodilator, or inodilator. Dobutamine will increase the contractility It will increase the heart rate, cardiac output, and also increase myocardial oxygen consumption, and this poses a risk of ischemia. It has variable effects on blood pressure and generally increases the blood pressure due to an increase in cardiac output. However, there's less afterload reduction. It also stimulates the release of renin, which can cause fluid retention and can cause the rise in blood sugar. So for the pharmacodynamics of Milrinone, it's essentially the same. It's an inodilator as well. It has similar effects on contractility. It will cause an increase in heart rate more due to reflex tachycardia from peripheral vasodilation rather than direct beta stimulation. And generally it has a less of an increase in heart rate compared to dobutamine. It causes less of an increase in myocardial oxygen consumption due to its beneficial coronary vasodilation and the drop in afterload, as well as a small rise in heart rate. It tends to lower blood pressure due to peripheral vasodilation, and it also acts as a pulmonary vasodilator, and this is beneficial because it reduces right ventricular afterload, therefore helps with pulmonary hypertension and right heart failure. It also lacks any of the metabolic or renal side effects that are found with dobutamine. In terms of the side effects for dobutamine, it causes increased risk of tachyarrhythmias and should be avoided in hypertrophic obstructive cardiomyopathy or any left ventricular outflow tract obstruction pathologies. And also there should be wary of tachyphylaxis because there's a downregulation of beta receptors over prolonged duration of a dobutamine infusion. In terms of the side effects of Milrinone, overdoses and prolonged infusions in renal failure can cause severe hypertension. Milrinone should also be avoided in hypertrophic obstructive cardiomyopathy or any LVOT obstruction pathology. Okay, we're at that part of the video we're going to recap. So, highlighting the major differences here, dobutamine and Milrinone have the same uses, but Milrinone, because of its beneficial pulmonary vasodilator properties, is better in right heart failure and pulmonary hypertension, and it can work for beta blocker toxicity because of its mechanism action by working on phosphodiesterase 3 inhibitors rather than at beta receptors. In terms of the presentation, the main thing to mention here is that dobutamine comes as a racemic mixture. The other key things to highlight that dobutamine has a much more rapid onset and is highly titratable, and this is due to the pharmacokinetic properties, where dobutamine is rapidly metabolized by catechol-O-methyltransferase. And the other important thing to note is that the duration of Milrinone is quite prolonged in renal failure, and this is because it is renally eliminated as unchanged drug. In terms of the pharmacokinetic, the major differences here are primarily that Milrinone has beneficial effects on myocardial oxygen consumption and causes less oxygen consumption than dobutamine. It has beneficial pulmonary vasodilator properties and helps to reduce right ventricular afterload. And it doesn't have the metabolic or renal side effects causing increased blood sugar or fluid retention that dobutamine can. And the main things with the side effects is that dobutamine is more likely to cause tachyarrhythmias, whereas Milrinone is more likely to cause hypotension. Alright, that's the end of the video. Thanks for watching, guys. Make sure to subscribe if you're new to the channel, and please like the video if it's helped you out. Please comment below for any questions you have or topics you want me to cover in the future. And just remember, every day you are learning more and more.